Yes, can we start?
Yes, sir. You can start. You can start, sir.
Hello.
Raju, go
Yes,
ahead.
sir. Yes, sir. Yes, sir. Good morning, all. Today topic for the discussion is acute kidney injury. The acute kidney is a clinical syndrome. It is a result from the multiple etiologies and comorbidities in suspecting patient may result in the multiple complication. First, we discuss the AK. First, come to the history. It's not moving this slide. It's not moving. It's not moving slide, sir.
Chandresh, do you have the presentation with you? Chandresh?
Sir, now is coming, sir.
Yeah, go ahead, Raju. Go ahead.
History. First, Econian notes that the first description of the ARF. Thereafter, they are coined by William Heberdal in 1802, Hixura renalis. Then ARF then renamed as a acute brain disease in 20th century by the William Shasta textbook of medicine in 1909. Then in first of our time, the F. Davis in the Lancet, they defined as a one nephritis in 1917. Then actually the credited for introduced the acute renal failure term 1951 by Homer with Smith, the kidney structure and function in the health and the disease. Then we're going to discuss the contents of topic for AK definition by the Rifle and Akin criteria and critical criteria. Then prediction and risk assessment of the AKI and biomarkers of the AKI and management of the AKI. In AKI has number of clinical definitions. As AK decrease the kidney function over the hours to days due to an injury leads to the functional and structural changes in the resulting in the ability to maintain the acid-base fluid and electrolyte balance to excrete the nitrogenous waste. Over 300 to 200 clinical definition was there. Is the most acceptable classification were refill criteria that is proposed in the 2004, Edikin is 2007, and Kidgo is in 2012. Then we are going to discuss the rifle criteria. The rifle criteria is proposed by the acute kidney dialysis quality initiation, and the proposal in the 2004. According to them, they are proposed as an acronym as a rifle, RIFFLE, that is risk injury failure loss and end stage kidney. Their definition regarding the GFR criteria, they include the GFR criteria and serum creatinine and urine output. In risk criteria, they increase the serum creatinine rise of the 1.5 times per baseline or GFR from the more than 25%, and urine output criteria, urine output less than 0.5 ml per kg per hour for 6 hours. In injury, increase the serum creatinine 2 times or GFR decrease more than 50%. Urine output decrease 0.5 ml per kg per with a 12 hours duration. Then failure, they increase the serum creatinine 3 times and GFR decreases by 75% or acute serum creatinine more than 4 mg per deciliter or acute rise in the creatinine more than 0.5 mg per deciliter. In urine rifle failure criteria, urine output decrease the 0.3 ml per kg per hour for 24 hours or anuria for 12 hours. Then according to duration, loss is a more than acute renal failure is a more than 4 weeks. End stage renal kidney disease is a more than 3 months of duration period. The mainly implication of the rifle criteria to predict the as the classification progress from the risk to end stage renal kidney disease, it increases the loss of hospital stay and mortality, and it causes a lower the renal response. That is nothing but an example. Any patient time of the discharge, if they have more creatinine level, they has to next prone to for the subsequent AKD and CKD. Then come to the Akin criteria. Akin criteria, they changed the modification criteria of the rifle. They removed the GFR criteria and removed the last classification and end stage renal kidney disease. Then they included as the acute rise of the creatine by 0.3 milligram per deciliter is added for 48 hours. Then the main difference, they concluded the serum creatine and changes occurs in the 48 versus 7 days. Then they considered the initiation of RRT at stage of 3. The comparison between the Rifle and Akin criteria we discussed before. The Rifle criteria, acute rise of creatine, they discussed with only over 7 days. Then rise of creatine in Akin criteria in 48 hours. Then Akin criteria, they included that RRT patient stage 3. Apart from that, the same Rifle as Akin. Then comes the critical criteria. Critical, there's according to critical criteria, definition of the AK is increase serum creatine by 0.3 milligram deciliter within 48 hours, or increase in serum creatine levels 1.5 times from baseline, or within 7 days of period, or decrease in urine creatine urine volume 0.5 ml per kg per hour for 6 hours. Then they are staged as 3 stages. The stages and serum creatine and urine output 1.5 times 9 times as the same as Akin criteria, but they included as they included less than 18 years of age, GFR less than 35 ml per minute or 1.73 square meter. But compared to the both studies, Rifle and Akin, critical is superior in view of predict on the mortality and diagnosis and hospital length of stay. That come to the metabolism of creatine. Why you need to know to the metabolism of creatine? Creatine is not exact surrogate marker of the AKI. It is extrapolated by some other reasons. Example, muscle failure, muscle disease as a renal disease. We know the metabolism of the creatine. Creatine in the kidney, arginine glycine. In the presence of the arginine glycine amidotransferase, they form the guanidinoacetic acid and ornithine. Ornithine to transfer to the form the urea cycle. Then guanidinic acid transfer to the liver. In the presence of adenocyclomethionine, presence of the adenoguanidinic acid methyl transferase, they form the adenosyl homocysteine and they form the creatine to the cardiac muscle or skeletal muscle. Then this creatine, presence of the creatine phosphokinase, they convert to the creatine phosphokinase is the energy dense structure. It is present in the muscle and brain. Then non-enzymatic reaction of the muscle, the creatine convert to the creatine, which is filtered to the glomerulus and excreted by the kidney. Then before we discuss the Rifle, Akin and criteria, they have some limitation because their criteria they based on the urine output and creatine criteria. Normally, half-life of the creatine is 4 hours. In case of increase the GFR, if it's any alternate GRS, it takes time to 24 to 72 hours. So it may take for 24 to 36 hours for the creatine level to rise after definite insult of kidney insult. Then a true fall in the GFR may not be reflected by creatine, as we discussed before as the creatine metabolism. This is altered by the sepsis, liver diseases, and muscle wasting. That one more important limitation, need to reference note to the baseline function of the creatine. Then the urine outputs may be until renal function almost ceases. But obese patient, the weight-based urine output criteria may overdiagnose the AK. And the European Renal Best Practice Guidelines in 2012, they suggest that use the ideal body weight rather than the true body weight. Then main pitfalls of the urine criteria and serum creatine and urine output criteria, they delay the diagnosis of AK because conditions follow like reduced production of the creatine seen, conditions like muscle wasting, liver disease and sepsis. Physiologically increase the GFR in pregnancy. The over fluid resistation, they cause a diluted concentration creatine and interfere with the analytical measurement of creatine, which includes bilirubin, drugs like 5-cytosine and sulfoxetine. The overdiagnosis AK in obese patient, instead of taking the ideal body weight, if you take the total body weight, it is the overdiagnosis of AK. Pseudo AK, it is because of the extensive creatine administration in a buffer in the medications like dexamethasone and azartone. And misdiagnosis of AK, drugs is interfere with the tubular secretions like cimetidine, trimethoprim. Increased protein also leads to generation of the creatine independent of the renal function. Then oliguria due to acute transient release of the ADH, example post-operative nausea, pain, volume and depletion. the progression of CKD with gradual rise of serum creatinine. Then we'll go for risk assessment. The risk assessment is important that to know the patient have risk and insult. Risk and insult, the susceptible of patient is individualized. Then go to the progress to the AK. Then rapid renal response team as a proposed as a acute AK risk assessment score. That is nothing but F score. There's F1, F2, F3, F4. The F4 column contains a clinical scenario. Under that, present as a patient present with symptoms and signs, major and cardiac surgery, coronary angiography, polytrauma, burns, sepsis, diarrhea, mechanical ventilation, drugs like AC and ARBs, and vasopressors and contrast media. Then susceptibility is F2, the past of the patient, the susceptibility of the patient, which includes as a age more than 65, low income country, black races, BMI more than 30 kg per minute, and diabetes and hypertension, other comorbid conditions as liver and lung diseases. Then F3 criteria, there is included the physical examination and the present to the patient in an hospital stay. It had hemodynamic instability and dehydration, peripheral edema and ascites. You not put less than 0.0 ml per kg per hour. Then F4 criteria, laboratory criteria, it shows up serum creatinine more than 1.0 milligram deciliter, estimated GFR less than 60 ml, and anemia less than 1 gram, 11 gram per deciliter, proteinuria more than 300 gram per 3 plus or 3 plus, and hematuria, presence of the AK biomarkers. In this assessment, when the first time present to the patient, with triage the patient of the present according to the triage the F4 score, that is nothing but risk assessment score, AK risk assessment score. According to AK risk assessment score, is graded as a low, high, and moderate. If the patient is the low grade, no intervention can be done. If it's a moderate, we have to follow for 48 hours and repeat the F3, F4, nothing but physical examination and laboratory tests. Repeat the F3, F4 24 40 hours. If it's a negative for the F3 and 4 and 48 hours, we'll label as a low. If it's high criteria, assess for biomarkers. If biomarkers positive, electronic alert and inform the nephrology rapid response team. Then, once inform the nephrology rapid response team, they assess for the stratify the AK staging. AK staging is subclinical and clinical. In the clinical, KDIGO 1 and 2 criteria and AK avoid the evaluation of and finding of the AK cause. But to next to 12 to 48 hours. Avoid nephrotoxic agents, non-invasive testing, delay contrast media and possible, and monitor creatinine and urine outputs, ensure the volume status, perfusion pressures and hemodynamic stability, and avoid the fluid overload and avoid the subclavian catheter. Then the follow up the patient at hospital discharge. You can follow up after 3 months, 1 month in a period of 1 week, 2 weeks or 1 week, and 3 days. The over conclude of this flow chart, it makes the discussion to happen with nephrologist and surgeons in critical care to avoid the AK and its complications. Then the biomarker. Biomarker is a pivotal role in the prediction of the AK. What is the biomarker? So a biomarker is a characteristic that objectively measured and evaluated as an indicator of the normal biological process and pathogenic process or pharmacological response to a therapeutic intervention. What are the ideal biomarkers? How should the characteristics of the ideal biomarker? It is non-invasive, easily obtainable, measurable using the standard assay, and fast results and cost effective. Then when you need the biomarkers, when to use the biomarkers. Biomarker is to assess the risk assessment, early diagnosis as AK detection, or acute kidney rejection post-transplantation, and recurrence of the kidney disease in post-renal transplantation, and differential diagnosis, staging of the AKA, and management of AKA, and even the prognosis of the AKA. The types of biomarker. Biomarkers is broadly within the functional biomarkers. There is nothing but serum creatinine and serum cystatin level, and upregulated proteins, nothing but NGAL, nucleated neutrophil gelatinous adverse lipocalcin, kidney injury molecule and LFAB and interleukin 18. Low molecular weight proteins are urine cystatin C and enzymes like N-acetyl beta glucosamidase and alpha glutathione S transferase, pi glutathamine S transferase, and AP alkaline phosphatase. Then we are now a number of biomarkers there. We're going to discuss the important one, that is NGAL, KIM, and interleukin 18 and cystatin C. Now, first going to apart from that, biomarker specific for the particular part of the nephron, which is expressed from the particular part of the nephron. We see the cystatin C, any injury with glomerular injury, and indicates the PCT injury. In come to the total protein bind, beta protein microglobin, it shows injury to the glomerular and tubular injury. Carbonic anhydrase is the PCT injury, capsaicin B in the PCT injury, and beta glucosidase it is expressed in the PCT more than the DCT, and LDH is more in DCT. Then kidney injury molecule is expressed on the PCT, and NAC on the PCT. NGAL from neutrophil genitalize associated hypercalcin, it most for the tubules and collecting duct injury, and interleukin for the tubular injury, clustrin for the tubular injury. N number of is there. The most we are going to discuss now the NGAL. NGAL is the most constant biomarker found in the during AKI. It expresses normal at low PCT, low in the PCT, but it also present other than like lung, stomach, and colon. The base level of plasma glands are higher in the patient with malignancies and systemic bacterial infection and CKD. The level of urine NGAL may also elevated in the urinary tract infection, as it is useful for the early diagnosis of AKA and prognostic value for clinical outcomes such as RRT and mortality. So method to measure NGAL was urine NGAL, plasma NGAL, and ELISA. Then we are going to discuss regarding the kidney injury molecule 1. It is a one type of the transmembrane glycoprotein with immunoglobulin domain and mucin. Is not found in normal kidneys and urine. It markedly elevated in conditions like ischemia, nephrotoxic proximal convertebral injury, and renal cell carcinoma. It is markedly elevation in 24 to 48 hours after initial PCT injury. High urinary kidney injury molecule 1 associated with poor outcomes in the established AK and mortality need to be RRT. Then interleukin 18, it is a pro-inflammatory cytokine. It expressed in the distal convertebral tubule and collecting ducts of the normal kidney. Urine level of interleukin 8 were significantly higher and high sensitivity specificity for the diagnosis of acute tubular necrosis. In interleukin 18 significantly elevated before increase in before the serum creatinine level. It is an independent predictor of the mortality in the patients with ARDS. Then cystatin C is a protease inhibitor secreted by all nucleated cells in the body, freely filtered to the glomerulus and not secreted in the tubules. Less influenced by other factor other than the GFR. Therefore, change in the serum and urine cystatin level is more sensitive than the serum creatinine predict the changes in the GFR. Increased urinary cystatin C and alpha microglobin are predictor of the favorable outcome in the acute tubular necrosis. As higher sensitivity and higher negative predictive value for determining the GFR in the CKD patients. Then we come to the management of the management has stages which include the discontinuation of nephrotoxic agents when the possible, ensure the volume status and perfusion pressure, consider the functional hemodynamic monitoring, and monitor the serum creatinine and urine outputs, avoid the hyperglycemia, and non-invasive diagnostic workup, consider the invasive diagnostic workup, check for the changes in the drug dosing, consider renal replacement as required, and consider the ICU admission, avoid the subclinical catheter. Then the first we discuss the fluid. Fluid is not a drug. We should use the patient with cautiously. Over-treating or under-treating the with fluid, it is harmful to the patient. It leads to morbidity and mortality. Then, if cumulative balance of fluid 1 liter, it is increase the mortality by 1 to 1.5 times. As per KDIGO, suggests us using the isotonic crystalloids rather than colloids. That is albumin and starch. Then receptor that in 2005, sepsis and the patient in subset of patient in that sepsis and severe sepsis were randomly assigned to receive 100% hydroxyethyl starch or ringer lactate solution. The result shows that the mortality were not significantly different in the 28 days. But however, HS group had significantly increased the rate of higher rate in the AK, that is 34.4 and 22.8. Are more days of the requiring the RRT patient who required RRT patient used with HS group compared to the ringer lactate group. Then come to the SAFE study. SAFE study has done 2004. They compare as the albumin and the cell line for the pure station in the intensive care unit. The conclusion was there no mortality benefit for 28 days, and secondary outcome was no difference in the length of ICU stay and duration of mechanical ventilation and RRT. Then the study was in NEGM, chest trial in 2023. They studied in hydroxyethyl starch or saline for fluid resuscitation intensive care unit. There is a no significant mortality benefits 90 days or 6% of HS group has higher risk of AKI and need of RRT compared to the normal saline. Then Albino study in 2014 in NEGM, they resuscitated fluid and septic shock with albumin. They use as albumin. There is a multicentric open label trial. The conclusion no major survival between the 28 and 98 days, but it improves the hemodynamics. Then the is a small study 2019 NEGM presented. They studied the balanced crystalline versus saline in critical ill patients. Then it is a random cluster randomized multiple crossover trial. The conclusion no mortality benefit saline group and balanced crystallites, but increased risk of the saline group. Who patient will resuscitate the large volume resuscitation, they cause the hyperchloremic metabolic acidosis, which cause the renal vasoconstriction. It needs the result to the AKI and need of the RRT compared to the balanced crystallites. And SALT trial in 2010 was a single randomized single center. It is a study done the balanced crystallite versus saline in non-critical patients. They resuscitated patients with crystallites on group. One more group is a saline. Based in the ER, they registered in the ER, but conclusion was no difference in the hospital free days and between the balanced crystalline and saline. And as conclude of the fluids, there is the mortality benefit of type of fluid, but over resuscitation with saline and colloids are more harmful to compared to the crystallites. The vasopressors, generally after fluid resuscitation, we'll send vasopressors. It's not known to which vasopressor is agent more effective prevention treatment of the patient with the risk of AKI and septic shock. The most studies focus on norepinephrine, vasopressin, or dopamine. Now we listen to the VAST trial. The VAST trial in NAGM, it was a vasopressin versus norepinephrine infusion in the patient with septic shock. The conclusion was no survival between the low vasopressin dose along with noradrenaline, but noradrenaline alone is a refractory shock on the noradrenaline compared to the vasopressin. There is no mortality benefit as using the single agent as a vasopressin or norepinephrine. None of them show no benefit. Then, so the VANISH trial, it is a randomized controlled trial. They studied the effect of early vasopressin versus norepinephrine and kidney failure, but there is according to the concluded that the 28 days mortality and risk of length of ICU stay was no difference. But if you use the vasopressin as an early agent to the norepinephrine, when you are giving the norepinephrine less than 0.5 micrograms of binate, it is the chance to get early win of the noradrenaline. Then when we studied under dopamine, because the Angenix trial, it was done in the 2000. They studied in the low dopamine in the patients with early renal dysfunction. They included as the 328 patients admitted to the 20 participating ICU were randomly assigned to the continuous IV infusion, low dose of infusion at the rate of 2 micrograms per kg per minute, or the plasma admission to the CBC. The primary endpoint is oliguria and increase in serum creatinine. Interpretation was continuous low dose of dopamine at risk of the AKI does not prevent the progression of the AKI. That means the Angenix trial shows that there is a low dose of dopamine is an overall prevention of the AKI. Then the SOAP trial to the NEGM. This compares the dopamine and norepinephrine in patients treatment of septic shock. It is a multicentric randomized trial. The conclusion was no significant difference in mortality and dopamine group and the noradrenaline, but rather than the dopamine group as the adverse cardiac event, especially the cardiac arrhythmias. As to do both as none of the vasopressin or noradrenaline not benefit the mortality benefit, but a SOAP trial confirmed that use of the adrenaline as the primary agent for septic shock rather than the vasopressin. Vasopressin as a dopamine has more the cardiac arrhythmias compared to the noradrenaline. Kidigo, as per Kidigo, emphasized that vasoactivity should not be withheld from the patient with vasomotor shock to concern of the kidney perfusion. As per Kidigo, use of the vasopressin in conjunction with fluids, patient with vasomotor shock and the risk of AKI. As per Kidigo, using the low dose of dopamine to not recommended to prevent the treatment of the AKI. And as per Kidigo, it's not suggesting that using the fendolizumab to prevent or treatment of the AKI. Then diuretics has a main role of the maintenance of the prevention of the AKI, but there is no role in the prevention of the AKI in diuretics. We're going to discuss regarding the diuretics. Then the most important diuretic is a furosemide. The furosemide is a highly protein bound. It's not filtered through the glomerular, but it is actually excreted into the proximal convoluted tubule. But its mechanism of action is a thick ascending loop of Henle to sodium potassium 2-chloride. It blocks the co-transporter. Actually, when it blocks the sodium potassium 2-chloride, it excretion of the sodium through the urine. It causes loss of length of medullary osmolality and decrease ability to reserve of water, and it decreases the oxygen consumption and ischemic injury. Then we come to the furosemide test. Furosemide test is used to approaching the patient with oliguria to determine the intact renal function, because the furosemide test to whether to confirm whether renal function intact or not. That physiological furosemide test must be intact the function of the glomerulus, proximal convoluted tubule, loop of Henle. There must be no obstruction between the glomerulus and the Foley's catheter. Then is a flow chart showing the furosemide test to exclude the first adequate fluid resuscitation, persistent oliguria, and doubtful that fluid or vasopressor inotrope's challenge would be help. Then furosemide test was administered furosemide who patient are not exposed before in the 1 mg per kg for IV bolus, already exposed the furosemide with the 1 mg per kg IV bolus. Then the results that urine outputs more than 200 ml 2 hours, it passes the furosemide test. If urine outputs in 2 hours less than 200, they fail to the furosemide test. That means the urine outputs more than 2 hours in the renal oliguria may require the further fluid resuscitation. Then is the furosemide test failed, the assumed as a intrinsic renal failure, they may require the RRT soon. Then interpretation of urine output is a, if urine output improves, it resembles that kidney function intact, that causes smart kidney. If urine does not respond to the furosemide, the nephrons are not intact. It truly dysfunction. It is a dumb kidney. Then there is a in AK furosemide testers include the 295 patient, 35 are excluded for some other reason. That's like less than 18 years, had CKD, immediate RRT, and he had died before the randomization. And furosemide test enrolled 162 patient. In that of 44 patient, furosemide responsive. Among them 6 was received RRT. Then furosemide non-responders was 118 patient. Again the randomization according to the time early RRT and standard IRT. In 58 patient randomized to early RRT, 57 received the RRT, 1 is died before the RRT. In 60 randomized standard RRT, 4 received the RRT, 2 is died before the RRT. As discussed before, the outcomes of the furosemide test alone was fairly good predictor of the need for dialysis. And furosemide also predicted death for mortality, who has a furosemide response is only mortality 34%, and versus furosemide non-responder is 60%. And furosemide test was more accurate predictor of the mortality than the Apache and the SOPA scores. Then potential limitation for the furosemide tests. Even the CKD, we see the CKD patient of the baseline baseline GFR less than 30 ml per minute, or severe hypoalbuminemia, albumin levels less than 2 grams per deciliter, and frank hypoalulemia, and patient with evidence of acute tubular necrosis. These are patients, subset of patients. They are the limitation to the furosemide tests. Then the BMJ for BMJ that study for prevention of the AKI in using the diuretics. The meta-analysis was randomized control trials and RCC total of 84 patients. The conclusion was furosemide not associated with any significant clinical benefits in the prevention and the treatment of the AKI. High doses may be associated with the risk of the ototoxicity. There's a number of randomized control shows in the table form there. None of them not benefit the prevent of the AKI and none of the prevent the AKI and prevention of none of the prevention of the AKI and mortality benefit. This studies the not showing the mortality benefit and prevent the AKI. Then come to the contrast into the AKI. The exact pathophysiology of mechanism of the contrast into the AKI we don't know, but we proposed that 4 main mechanism is there. One first is osmotic diuresis. In osmotic leads to the hypovolemia and renal medullary hypoxia. It is due to the overactivity of the vasoconstrictor like adenosine and endothelium over vasodilator, which leads to the vasoconstriction. It leads to the renal hypoxia. Apart from that, renal direct toxicity of contrast agents with harmful to trigger oxidative stress and activation of the cytokine-induced inflammatory mediators. Then one more is mechanism is apoptosis may also play a role in the development of contrast-induced AKI. Then prevention and treatment of AKI. The fluid reduces the concentration of contrast media and subsequently it may minimize the risk of contrast media exposure and reduce the nephrotoxic effects. But it inhibits the RAS mechanism, minimizing the renal vasoconstriction. Then American College of Radiology and European Society of Urogenital Radiology both recommended that prophylactic use of prophylactic intravenous 1 to 1.5 kg per hour. The patient risk for AKI at least before after administration of contrast media. The sodium bicarb, it can reduce the risk of contrast into nephropathy by decreasing the free radical formation through make the urine as a alkaline pH. Then is N-acetylcysteine. N-acetylcysteine has an antioxidant effect. It is scavenger of oxygen-derived free radicals, which may lead to the proved endothelium-dependent vasodilatation. As per Kidney, using oral NAG together with IV solution, using IV isotonic solution, isotonic crystallites in patients with increased contrast induced AKI. That means Kidney, as per Kidney, using oral NAG with together IV crystallite to may decrease the risk of the increase contrast induced AKI. Then in NAGM, they studied that prevention of the radiographic contrast agent and induced reductions in the renal functions by acetylcysteine. They did the prophylactic admission of the N-acetylcysteine twice a daily and before the day on the day of admission of the contrast, along with the hydration to prevent the renal damage, it induced by the non-ionic low osmotic contrast agent in patient with chronic renal insufficiency. Then contrast into then dopamine. The dopamine Graham and et al. They did the study of the renal effect of the low dopamine in high risk patient with undergoing coronary angiography. Then their low dopamine they concluded that low dopamine doses failed to show the protective effect of the renal function in patient undergoing contrast media exposure and even associated with the later effects of increase the severity of the renal failure and its duration. Then prostaglandin even Coach et al. They did study the prevention of the renal dysfunction high risk patients caused by the contrast media. That study they concluded that they used as a 20 nanogram per kg per prostaglandin infusion and significant protect effect on the post coronary interventions creatinine elevation. But there is a higher infusion rates not associated with increased benefits, but probably it is due to decrease the systemic blood pressure. That means the dose of nanometers may prevent the contrast into AKI, but higher doses may cause the systemic blood pressures too. Then prevention of calcium channel blockers, Neuhammer HS and et al. There is a study in that using the nitrodipine in who patient has exposed to contrast. It is a randomized trial. The small randomized trial, the placebo trial, enroll 35 patients. The preserved GF that treated with nitrodipine decrease the patient with then the rasmus. That means there is no prevention of the AKI in the calcium channel blocker. And Caro and Machino, they also study contrast. There is 2 more studies, but the calcium channel blockers there is no role of prevent of the AKI. As per Kedigo, recommended that use of phenolopine to prevent contrast into AKI. There is no role of phenolopine preventing the AKI as per Kedigo. Then consider the alternative imaging methods if in the patient with increased risk of the contrast into AKI. Use of lowest possible dose of the contrast media in patient risk of the contrast into AKI. As per Kidgo, using either isoosmolar or low osmolar ionized contrast media rather than using higher osmolar ionized contrast media in patient with increased risk of the contrast into AKI. As per Kidgo, for volume expansion, they recommend the use of the isotonic sodium chloride or sodium bicarbonate rather than the no volume expansion patient with increased risk of the contrast into AKI. Then we do the role of the contrast AKI. Hemodialysis, ionized contrast agents are rarely dialysable, but plasma clearance of most of the modern contrast media is 50 to 70 ml per minute, with the more than 80% of removed the plasma within 4 to 5 hours. But however, reduction of contrast in AKI with dialysis is also not biologically possible, is because of the contrast media would reach the kidneys within 1 to 2 cardiac cycles. The subsequent removal of unlikely to stop the cascade of the renal injury, which have already begun. That means the hemodialysis cannot prevent the already started the cascade of injury of the renal injury, may benefit the patient before starting the insult. And hemofiltration. The hemofiltration, Merenji et al. The study in the NEGM, prevention of the contrast agent induced nephropathy by the hemofiltration. The patient which is chronic hemophilia who undergoes the percutaneous coronary intervention, peri-procedural hemofiltration given in the ICU setting appears to be effective in preventing the deterioration of the renal function due to contrast nephropathy associated with improving the hospital and long-term outcomes. According to them, they concluded that hemofiltration improve the renal function and if done the peri-procedural and improve the hospital stay and long-term outcomes. Then come to the drugs cause the nephrotoxic agents. Number of drugs are there to cause the nephrotoxic which lead to AKI. Now we are going to discuss the important drug, that is aminoglycoside, where day-to-day practice using practice is the misusing the aminoglycoside, which leads to the AKI. AKI risk factors for, now come to aminoglycosides. Aminoglycoside risk factors for the aminoglycoside to induce nephrotoxicity. The following criteria is age more than 65, patient with pre-existing renal failure, septic patients with intravenous depletion, diabetic mellitus, and concomitant use of the nephrotoxic drugs and prolonged use of the excessive blood levels. Then repeated exposure to the separate course of the aminoglycosides with therapy cover for short time of intervals. Then prevention of AKI, prevention of the aminoglycoside AKI. As per KIDGO, not using aminoglycosides for treatment of infections unless no suitable less nephrotoxic agent and therapeutic alternative are available. If they suggested not to use aminoglycosides until there is a therapeutic indication, or if available any other medication which is a less necessary, we go for that one. Then as per KIDGO, the suggestion normal kidney function is steady state as aminoglycosides are administered single dose rather than the multiple doses at treatment for regimens. Then they suggest that use the rather using the multiple doses, use the single dose for treatment regimen. Then KIDGO recommends that monitoring the aminoglycoside drug level when the treatment multiple dose is using, use the frequency more than 24 hours. Then as per KIDGO, aminoglycoside drug monitoring should be done when they use the only single dose after more than 48 hours. As per KIDGO, used for topical or local applications of aminoglycosides, for example, respiratory aerosols, installed antibiotic period rather than the IV administration when the feasible and suitable. Then the amphotericin B is a broad spectrum antifungal. It has a nephrotoxicity, but it has 3 formulations. Reduce to risk of the which because of lipid formulation, less risk of the AKI compared to the conventional formulation. These forms includes amphotericin B colloid dispersion, amphotericin B colloid complex, and liposomal amphotericin B. Other formulations which includes amphotericin B included in the nanoparticles in micelles and with polyaspartic acid. Then as per KIDGO, lipid formation of amphotericin B rather than use the lipid formulation rather than using the conventional formulation amphotericin B. The KIDGO is a treatment of systemic mycosis or parasitic infection. Recommend that using azole antifungal agents and economic agents rather than using the conventional amphotericin B if it's assumed that equally therapeutic efficacy is assumed. Then go to the next management is a glycemic control and nutritional support. As per KIDGO, critical ill patients suggest nutrition therapy to target plasma glucose level. This is 110 to 149 milligram per deciliter. KIDGO suggests that achieving the total intake 20 to 30 kilocalories per kg day in patient with any stage of AKI. As per KIDGO, restriction of protein intake with the prevention and delaying the initiation of RRT. That KIDGO suggests following protein intake as follows: the critical illness, 0.8 to 1 gram per kg protein in non-catabolic AKI patient without need of RRT. Then patient who has an intermediate hemodialysis, he requires, they suggested that 1 to 1.5 gram per kg protein. And then who patients in hypercatabolic states, on CRRT, they suggest that 1.7 gram per kg per protein per day. Then going to we're going to discuss the hepatorenal syndrome. By Efferent syndrome, according to cirrhosis patient, they defined as definition accordingly: acute dialysis quality initiation, and International Club of Ascites in 2000 they defined that they took the criteria: increase the serum creatinine at least 0.3 milligram per deciliter, or increase the creatinine 1.5 from the baseline. They found 3 stages: increase the creatinine 0.3 milligram per deciliter within 48 hours, or 1.5 2 times from baseline. Stage 2, increase the serum creatinine from 2 to 3 from the baseline. The stage 3, at least increase the serum creatinine for 3 times from the baseline, and an increase of the 0.5 milligram per deciliter, or the patient on RRT or currently. Then again, they revised in the criteria in 2015. Then International Club of the Ascites, they included that absolute increase of creatinine at least of 0.3 milligram per deciliter within 48 hours, or 1.5 times the baseline creatinine. They include as a time frame compared to the previous they are not that the last 7 days of duration time. They included this criteria. Then stage 1, they divided stage A1, stage B according to the absolute creatinine value less than 0.5, and stage B is the serum creatinine level is more than 1 milligram per deciliter. And this stage 3, they included the creatinine level more than 4 milligram per deciliter. Then HRS, hepatorenal syndrome causing the AKI. This is a criteria for the HRS. To diagnose HRS, criteria should be filled that presence of the ascites, no improvement of creatinine after holding of the diuretics, no improvement of albumin, even though no improvement of creatinine after 48 resuscitation of the supplement of albumin at the rate of 1 gram kg per day. No, there should be absence of the shock, no recent nephrotoxic administration like antibiotic, contrast, and NSAIDs, the no signs of kidney disease, the proteinuria, microhematuria, no findings on renal ultrasound. Then the classification is HRS type 1 and type 2. Type 1 is the rapid progressive of the kidney disease, rapid progress of AKI, with baseline creatinine ranges from the 2 to 2 milligram per deciliter, or reduction in the serum creatinine clearance of 50%. And type 2 HRS is the slow progression of the AKI. Its creatinine ranges from the 1.5 to 2.5 milligram per deciliter. And as a definition of hepatorenal syndrome AKI, we discussed it before in the International Club of Ascites and AKI in 2015. Then non-hepatorenal syndrome AKI, they have the 3 typical forms of AKI in cirrhosis patient, which includes renal azotemia. The mainly is the most frequently come with the large volume paracentesis and upper GI bleed and shock. Infections and sepsis, like urinary tract infections, pneumonia, skin infections, and spontaneous bacterial peritonitis. And parenchymal disease, which includes autoimmune diseases, drugs which causing the parenchymal disease, infections like hepatitis B infection and hepatitis C infections. The drug-induced AKI, most commonly laxatives are lactulose, and apart from lactulose, diabetes can cause the drug-induced AKI in cirrhosis patients. Then it is a showing the pathophysiology of the hepatorenal syndrome and non-hepatorenal syndrome induced AKI. The first, cirrhosis causes the increase the rise of the portal hypertension. Because of portal hypertension, splenic vasodilatation, arterial dilatation, it causes a decrease the effective renal hypovolemia. It activation of the vasoconstrictor factors, then cause the renal vasoconstriction. Apart from that, any infection that causes the activation of the pathogen ascent particles and damaged association molecular pattern that cause the inflammatory response, then leads to the kidney injury. Any patient with background of cardiac issues will decrease the cardiac output, they cause the effective hypovolemia, then trigger of the renal vasoconstriction, then leads to the renal ischemia and hypoxia, then lead to AKI. Then treatment of the HRS. Then in patient with cirrhosis with elevated creatinine, to prioritize the patient is the HRS or not. Regarding the criteria, we do, improve absence presence of the ascites, the improvement of the improvement is after giving albumin, improvement of creatinine after stopping the diuretics. If is no, if patient may have other disease. If yes, conclude the baseline creatinine is higher, we consider the other disease. Baseline is low. Before was the baseline is before low. We consider as a hepatorenal syndrome as criteria meets the International Club of the Ascites and AKA criteria. Patient treated as the HRS. Within ICU, we treat the patient with noradrenaline with albumin in without outside the hospital. Outside the ICU, we treat the 10 mg with albumin. If it's not available, treat the midodrine and octodad with albumin. If this treatment not respond to the patient, we treat the liver transplantation. Then before transplantation, bridging therapy was there. Nothing but is the transjugular intrahepatic potassium stent and molecular absorption recycling system. It's a form of albumin dialysis which circulates the albumin to remove the cytokines and bacterial products to combat vasodilation. So one of modality of that is a bio-artificial liver support, bridges the patient with cirrhosis to transplant to or recovery. The last topic is sepsis associated with AKI. The sepsis accounts for the 45 to 70% of all causes of AKI among the critical ill patients. Sepsis associated AKI is classified according to duration, early and late. In early, the AKI diagnosed within 48 hours of the sepsis, we defined as early sepsis associated AKI, but late sepsis associated AKI set in between the 48 hours to 70 days of sepsis, diagnosed be classified as a late sepsis associated AKI. Then pathophysiology of sepsis is a heterogeneous syndrome. It has a multiple mechanism contribute to injury with varying intensity between the patients across the course of the sepsis. In the patient sit in the sepsis, mainly the gram-negative bacilli. Gram-negative bacilli has a cell membrane, is a lipopolysaccharides, which is a cause endothelial damage. It causes the increase the pathogens associated molecular pattern or damage associated molecular pattern, which intensely trigger the pro-inflammatory cytokines or the pro-inflammatory and inflammatory cascade, thereby increasing the increase the oxidative stress and adaptation of tubular epithelial cells and increase the cells arrest and apoptosis. Then pro-inflammatory also it causes the microvascular and microvascular dysfunction, thereby increase the renal intrarenal shunts and increase microthrombi in kidney perfusion and oxygen waste and compromise, increase the endothelial leak. It causes to the AKI. Take home message. Diagnosis of AKI by urine output and serum criteria by the Rayfield, Aiken criteria, and Kidgo criteria. And rather than the Rayfield and Aiken criteria, Kidgo is a superior to in perspective of diagnosis and prediction of the AKI and mortality. The biomarkers plays important role in the risk assessment and early diagnosis and prognosis. Fluid is a drug used as cautiously. Use the particular the scenario, prioritize the patient, which type of fluid, how much volume we should use the patient. This is so much important. Then treatment goals in the patient with AKI includes both reducing kidney injury and complication leads to the decrease in kidney function. Thank you. Sir? Hello, sir.
Yes, Raju.
Chandresh, you want to add something?
Yeah, it was a informative presentation, Raju. Everything about AKI, the risk factor, and particularly the nephrotoxicity drugs which causes the AKI in the ICU. No more question from my side, sir.
Ghanshyam?
Just a couple of points. Yes. See, AKI is one of the most common organ failures that you'll come across as a part of multi-organ system involvement in patients who come to the intensive care unit. And by and large, most of the times it's multifactorial. So always try to look at the multiple reasons why patients with who come to the ICU end up with acute kidney injury. We have severe limitations in respect to identifying AKI for the simple fact that we rely heavily on urine output and creatinine, both of which are not very sensitive nor very specific to pick up kidney injury, because you need at almost 50% of your nephrons to be lost for your creatinine to start increasing. So if you're relying heavily on creatinine, then by the time your creatinine is increased, a significant amount of kidney injury has already happened. So we have the facility and the feasibility. Try to look at the biomarkers, especially the cell cycle as biomarkers, which seem to kind of predict or pick up kidney injury early. In intensive care unit, please do keep a very, very close watch on the various factors, especially your nephrotoxic interventions. Any iatrogenic intervention which can contribute to kidney injury should be very, very carefully reviewed with respect to whether that kind of weigh your risk to benefit ratio before you start instituting such interventions like be it antibiotics, be it contrast studies. Until unless you have a very, very strong risk to benefit ratio, try and relook at other strategies. I think we will deal with the management aspects, the RRT modalities in the next class. So I think those are a couple of points which I want to add.
Yeah, so I think most of it has been covered. I only want to add that AKI, the current understanding of AKI is currently very similar to what is happening with ARDS. There was a time when we used to call it acute lung injury, then we called it mild, moderate, severe. So that kind of stratification of acute kidney injury as an entire syndrome is still missing. You still have some, classification of failure and mild, moderate, and severe failure, but we don't yet have a strong classification system like ARDS, which will tell us this is the class of ARDS or AKI for which this is the treatment. For example, in ARDS, you have a mild ARDS where you can use high flow nasal cannula, you can use CPAP, you can use other non-invasive methods of respiratory support. We don't have such guidance whether we should use RRT in stage 1, stage 2, stage 3. We know it is too late if it is crossing stage 3, so we don't yet know the complete understanding of AKI. There are several classifications of AKI which are now coming up, which are biomarker-based classifications, which will tell us early where even before the injury has happened, these patients are already having some kind of functional damage to the kidney. Like in ARDS, like in sepsis, there are several phenotypes of AKI which have been identified. Now it's an era of phenotypes with the availability of artificial intelligence and machine learning platforms where non-renal parameters like mean arterial pressure, vasopressor dose, PaO2 by FiO2 ratio, albumin, these are all considered to be determine different phenotypes of ARDS, and a combination of these phenotypes will decide whether the person with AKI will ultimately end up with RRT or will not end up with RRT. So there are multiple issues with the classification of AKI. When you talk about nephrotoxic drugs, it is not just restricted to aminoglycosides and diuretics. Quinolones, which are very rampantly used for every single indication from pneumonia to enteric fever to urinary tract infection in this country, are known to produce interstitial nephritis, and interstitial nephritis does not present with oliguric AKI. That is another one important nephrotoxic drug which we use. We use voriconazole, so the intravenous formulation of voriconazole is nephrotoxic, so we need to be aware of it. So the list of drugs which are so-called routinely used in the ICU, which are nephrotoxic, is increasing, and we should have our eyes open for any patient who is at risk before we prescribe some of these medications. So that brings us to RRT. RRT is a big issue, big topic, raging debate. So that will be dealt with by Dr. Kalyan, and we will talk about it next week. So if you have any queries, please post them on the Higgs group, and one of us will try to answer these questions. Thank you very much for joining. Please join us again next week.
Thank you, sir. Thank you, sir.
Thank you.
Oh. Yeah, no. Hello.